A number of the recorded lectures have been pretty widely used. So I'm going to start today by talking about joint types. Another term for that is articulation. Articulation is a term that what happens when two levers come together and move relative to one another. That spot where they move is called an articulation or a joint. The classification of a joint that is most useful sort of depends on what your approach to the joint is. If you're suspecting a cell or a tissue or even an organ involvement within the joint, you're trying to fix that, then you're going to be most interested in, is that a cartilage joint? Is that a fibrous joint? Is it a synovial joint? In other words, a structural classification. If you're dealing with issues like arthritis or restriction of movement, physical therapy to restore movement, you're interested in a functional approach. Is the joint in good health? When in good health, is it immovable? Is it slightly movable? Or is it freely movable? So we'll look at these different classifications. We're going to talk about the location in the body, and always when we identify a joint, we're going to need to talk about the joint and the bone or the involved. Look first at this statement about joints. There is a trade-off between mobility of a joint and the strength of a joint. With mobility, allowing for movement, but subtracting strength. Immobile joints are the strongest. Freely movable joints are the weakest, and within those, the synovial joints, there are so many freely movable joints with synovial capsules and synovial fluid surrounding the joint. But there's a lot of difference in the amount of strength within those synovial joints. So just to make an obvious comparison, our hip joint supports our weight whenever we're not standing or sitting or lying down. We stand up and we put our body's axial skeleton and upper appendicular skeleton, all that tissue weight goes on our hips. So it has to be a much stronger joint than our shoulders. Our shoulders are free to move, free to carry, but when we're walking, basically all we're doing is swinging our arms. So we're going to combine all that information with the description of movements, going back to some of the terminology we used when we started talking about the body at the very beginning. We'll look at some of the more obvious joints, the shoulder and hip joints, the knee and elbow joints, and see how they're constructed, because they represent complex and freely movable joints that have all the structures that we find in those joints. There's going to be a big link between Chapter 9 and the labs that we do. So the articulation labs, I actually used to rely quite heavily on this to explain joints and how they work. Let's talk about the movements first. And this particular figure presents a lateral view of a human figure and defines the movements that are angular movements around the joint in the anterior and posterior plane. So in this figure, left to right on the body, anterior and posterior. When we talk about movement, we are using the spot to identify the joint. So this spot is right over the hip joint, the head of the femur in the acetabulum of the coxal bone, and this shows the rotation around that point. Now, from the anatomical position, which is the standing leg, this joint can move forward. We call this flexion of the hip. flexion of the hip if it's moving in the anterior direction. We return it, it is called extension back to the anatomical position. And if the joint, like this hip joint, is capable of moving further in that extension position, past the anatomical position, we would call this hyperextension. This is possible in certain joints that are multiple, where there are multiple joints present, or ball and socket. What we're identifying with this next spot up here is the elbow joint. You notice in the anatomical position, we have a 180-degree angle at that joint. And this second arrow identifies flexing the elbow and then returning it to this position is extension. Now you'll notice when the model did this, she also flexed the shoulder joint somewhat because it's moved from this position up to this position. But we haven't named that flexion of the shoulder. That's why it's important if I gave this figure and said, what is this movement? For you to say flexion of the elbow. Now, unlike the ball and socket joint, this particular part of the elbow is a hinge joint. And so we're well familiar with this, that basically from the 180-degree position, we flex, we extend it. We can basically feel that stop. And that's because particular bone markings are hitting into each other and preventing hyperextension of the elbow. Up here was the third presentation showing the neck, the base of the neck, allowing us to flex the neck and extend the neck. And because of the flexibility of vertebral connections, we can also hyperextend the neck. This is a movement of the head, and it's based on a number of different joints here in the neck, so it is a complex movement. So anterior and posterior plane, flex in the forward, extend in the return, and if you can go beyond the return to hyperextension, then that's typically a ball and socket joint. Looking at the model rotated 90 degrees, here are angular movements around the medial and lateral plane. Now, reminding that our terminology in the anatomical position defined this midline. Medial meant moving toward the midline. Lateral meant moving away from it. And we're identifying two joints here. This joint is, again, the hip joint. And when we rotate the leg away from the midline in the lateral direction, that's called abduction when we're moving in this direction. When we are returning, that's adduction with a D. Away from the midline, ab with a B. Returning, adduction with a D. You can see the similar analysis right above for the shoulder joint, another ball and socket, as we abduct and adduct. Now, this is a little bit confusing on the other side, showing us abduction and adduction, but not up here. We're seeing that down here at the wrist. So this would be abduction of the wrist. This is shown for the other hand right above in the enlargement. If you move the hand away from the midline, that's abduction. And to return, adduction. But we're not actually through with the hand just yet. We can also recognize there's a midline here in the appendices, in the appendage, right through the number 3 digit. If we spread away from that midline, we are abducting. If we return back toward that midline, this particular movement would be called adduction. Rotational movements. We are pivoting around an axis. In this case, the right rotation and the left rotation is for the neck. This is the axis to atlas connection. And it is right on the midline, so left and right describes it very well. For the lateral joints, such as the shoulder, we can rotate the shoulder to turn the hand over. Notice that from the anatomical position, which is this lateral figure, we turn it over with the thumb moving toward the midline. That's medial or internal rotation. We'll have another term for that in a moment. Or we can return it. That's lateral or external rotation. The other terms for those are shown here. Internal rotation is also called pronation. Notice the palm of the hand is down, backwards. And supination, if we return it to the anatomical position. I also like this figure showing pronation and supination because of its demonstration of what the bones of the forearm do with the radius lateral and the ulna medial in this anatomical position. When we pronate, notice that the ulna remains posterior, and the radius, basically the head of the radius, is rotating on this capitulum of the humerus and producing a shift in position. The radius rotates over the ulna, and notice it produces this X configuration, and now the hand is pronated. Now, excellent tables on structural and functional classifications of the joints in the body. And the functional classifications sort of take the lead for the table itself. So this is an example of synarthrosis, where no movement is seen in the mature joint. Now understand, we start as a single squishy cell, so there's always a developmental aspect of this. We're not born with immovable sutures. We make them. While we're making them, by endochondral ossification, that is a type of developmental joint. It's a cartilaginous joint, and it's ossifying right up to the point where it makes the fibrous connections that lock them in place. So in looking at these four joint types, what we notice are a number of structures that basically lock the bones together so they do not move. Up here at the top is the fibrous joint, because the connections are all strong fibers like collagen. This kind of joint is called a suture, and it is a synarthrotic joint, immovable. So the purpose of this joint is to produce the cranium, this hard, continuous, bony covering that protects the brain, that produces that combination of cerebrospinal fluid and layer upon layer upon layer of different protective tissue that keeps the brain free from movement and free from shock. A dense fibrous tissue is deposited, and it laces these bony edges together, sort of like bootlaces, and it is so tight that it normally does not break apart even with aging. So if you find an ancient skull, if you're looking in anthropology or archaeology and you discover a skull that was intact when the body went into the ground and it was not crushed, I mean, if the ground moves, if the rock layers move, it can crush skulls. But if it's uncrushed, this skull, even if it's 10,000 years old, will come out of the sea or come out of the land as a single skull. Now, a second type of fibrous joint is just really a specialized suture. It's called a Gong Ptosis because we have a special terminology for our dental medicine when compared with the medicine of the whole body. A Gong Ptosis refers to the ligament that connects the tooth to the base of the bony socket. This is tying together two bony elements with a tight ligament. This is called the Periodontal Ligament. And again, it's a specialized kind of suture with a special name. So it is possible to say that in the skull, you basically have one movable joint, and that's this one right here, the temporomandibular joint, or TMJ. It is freely movable. We move our jaw for chewing, we move our jaw for the positioning of our food, and we move it up and down when we are speaking. Very, very mobile joint, the TMJ. Every other joint in the skull, including the connections of the teeth in their socket, is a fibrous joint and is a type of suture. Now, this is one of the things to kind of realize. If I had to count the number of sutures in the head, I would be very indefinite about that. I don't know how many sutures there are, but every bony joint, except the TMJ in the skull, is a suture. They're all in one place. Now down below is a second kind of synarthrotic joint. Synarthrotic joint. And it is cartilaginous. Now this one is a very special joint. It occurs in only two places, and those two places are left and right. It is a rigid bridge of cartilage right here that connects the number one rib between the rib itself and the manubrium of the sternum. Unlike these other straps, which are flexible and do allow for movement, this joint, called a synchondrosis, is immovable. And the reason is so easy to understand. We're sitting at rest, we're breathing at rest. Our diaphragm is taking care of our oxygen needs. There really isn't that much oxygen that we're burning. Most of our needs are constant, and our respiratory system handles it with ease. But when we begin to use our muscles, we begin to burn more nutrients, make more ATP and burn them, use more oxygen. And in order to maximize our oxygen exchange, we're going to lift our rib cage. We're going to do that by using the muscles between the ribs, called the intercostals, to pull the ribs closer together. Now, to pull the ribs up, you have to have something at the top that's immobile, and that's what this synchondrosis does. Is it immobilizes a small ring between the vertebral column, which is back where the pointer is, then that number one rib curves around to a very firm connection to the manubrium. If you have a chance to look in the bone drawer or to look at actual ribs, you'll be surprised. The ribs we're accustomed to are this long, and they have a big curve in them. The number 6, number 7, number 8 rib are good examples. But up there in the number 1, first of all, it's wide and it's flat, front to back. And secondly, it's smaller than that. It makes the top of the thoracic cage very narrow, so the opening in the top is only about like this. This is where the major blood vessels and nerves go from, basically out of the thoracic cavity and up to the neck and head. This is where the esophagus and the trachea are basically entering the thorax for the delivery of their nutrients and their air. So this synchondrosis is really quite unique in the body. Finally, there's this example of bony fuses called a synostosis. Synostosis. A synostosis is a developmental joint. As I said, these bone plates are growing. You know, the head of a infant is about this big, and the skull is this big. It has to grow throughout life. And at the time that you're achieving your maximum bony growth in the skull, there are places where two bones that started as growth centers, left and right, are meeting and growing together, but instead of making a suture, they basically continue to make bone. So we call it one frontal bone, even though it develops from left and right growth centers, because when it meets here in the middle, it fuses by bony growth. Now, the frontal bone is kind of an obvious application of that term. Another place where this occurs is in the pelvis. The coxal bone has three growth centers: the ilium, the ischium, and the pubis. And they have those endochondral junctions that continue to grow until the coxal bone and the formation of the pelvic bowl is complete. And then those three elements fused together by synostosis. Synostosis, bony growth. And as we can imagine, the strongest joint would be a synostosis, where you have solid bone, stronger even than these sutures. So that's a discussion of immovable joints. Very, very strong, and for obvious reasons. Let's go on to slightly movable joints. There are places where locking two bones together is critical to the functioning of our body. You know, our body didn't start out as a biped body. We were quadrupeds before we were primates. Primates with their climbing and their grasping. We added a quadruped locomotion to a climbing habit. Everything that climbs pretty well has what? Hands or claws, and sometimes both. Most of the things that can go up trees can grab a hold of you in some way. And so that speaks to a modification of the appendages and their ends. Amphiarthrosis means very little movement. There are two kinds shown here. Some of them have fiber connections, again, very, very strong ligaments of collagen, and some are cartilaginous. This is a little bit confusing because some of the cartilage pads are fibrocartilage. So people often ask me, are they cartilaginous or are they fibrous? What I can tell you is that the fibrous joints, like this syndesmosis, is all collagen. It's a pure ligament. Collagen fibers locking those bones together. If there's any cartilage present, even if there's a lot of fiber as well, we will call that a cartilaginous joint. So let's go back. A little movement. Where do we need a little bit of movement? Well, this joint that is shown here is the distal articulation between the tibia and the fibula. This is what's forming that joint with the talus, the hinge joint that basically connects the foot through the ankle to the lower leg. And we make this joint out of two different bones. So the tibia has a little cavity like this, and the fibula lies in that cavity, and the fibers lock them together to hold that talus in place and not allow it to move left to right. So this strong amphiarthrosis allows little movement between the fibula and the tibia. Now, I'm not talking about the joint between the talus and these two bones. That's a synovial joint. But this fibrous joint, a syndesmosis, occurs left and right at the bottom of our legs. This cartilaginous joint is called a symphysis. And here we have a wedge of cartilage that acts as a sort of a pad with a strong fiber content. This is the articulation between the two pubic bones shown here, but it is strongly reinforced with fiber, and it is called a symphysis. A symphysis is rigid in males. Basically, there's very, very tiny movement between the pubic bones in males. In females, there's basically very little movement except during one event of life, and that is the delivery of a baby. Turns out that one of the human's basic problems is getting the baby's head out during childbirth. The size of the baby's head compared to the dimensions of the pelvic brim are so close that often delivering the head of the baby is very difficult. So one of the things that happens with the hormones as gestation nears completion and as parturition is beginning is that there's a softening of this symphysis, allowing for a little bit more separation here in the front. And what you're doing with the pubic symphysis, if you can imagine my thumbs being the vertebral connection and this being the pubic symphysis, you can kind of see that if you allow just a little bit of stretching, that actually increases the radius of that brim significantly, allowing for the passage of the baby's head. Now, so far we've talked about no movement, and we've talked about slight movement. And those are the ones which have bony growth, fibrous connections, and cartilage connections. Bony growth is always going to, synarthrosis is always going to be an immovable joint. You lock it together with bone, there's not going to be any joint movement. But there's overlap between the immovable joints and the slightly movable joints when you talk about fibrous and cartilage structures. However, the final category of function, diarthrosis, refers to free movement. A diarthrotic joint is always synovial and vice versa. That means that the structure you see is distinct, having a synovial cavity, and the padded, the hyaline cartilage that's on the joint surfaces, the articular surfaces, will pad and lubricate the movement. But added to that, this white space that you see here is filled with synovial fluid. So we're going to support the joints not just with pads and with slick surfaces, we're going to support them with hydraulic pressure. So when we have a synovial joint, it's always freely movable, and we can just start talking about how many planes that movement will move in. And here we think about the planes would be like the axis of a graph. Does it just move along the x-axis? That would be monoaxial. Does it move in two planes, x and y? So movement in one plane is like the elbow or the ankle. You can see that this arm forms a plane, and the flexing of the elbow or the flexing of the ankle, that's talus on lower leg, is a monoaxial joint. Biaxial refers to two planes. Ribs move in two planes, and so do wrists. So I can take my wrist, I can't hold it in the anatomical position and get the camera, but I can move it this way. I can move it this way. And that's actually the result of many joints. This is not a specific joint. This is the cumulative action of all of these planar joints that are present here in the wrist. We'll talk about that in a bit. Finally, there's triaxial, but not in the standard solid geometry sense. Because if you move in X, Y, and you move in, in X and in Y, Z would basically pull the joint out of socket. So triaxially means three planes, with the third axis being a rotation and not a dislocation. Here's the typical synovial joint, and just to name the parts, here is the bone, that epiphyseal line, the spongy and medulla elements of a bone above and below, and the periosteum. We're going to return to that outer continuous membrane that provided the fibrous connection, rich in collagen that's embedded here in the bone, strengthening the connection of that periosteum to the outer part of the bone and providing ample spaces for the living osteocytes that are maintaining that bone surface. Now, when you get to the joint, a funny thing happens. The periosteum becomes the fibrous joint capsule that crosses the opening and merges with, or a better term, is continuous with the periosteum on the lower joint. Now, this continuous capsule is shown in profile here, but it basically is a 360-degree enclosure that circles the joint cavity that's created by that strong structural support. What do I mean by is continuous with? Well, the periosteum is continuous with, attached to, the embedded collagen that penetrates in through the bone, that fibrous content that gives the bone its flexible strength, reinforces the bone against too much movement so that it preserves it from cracking. So that comes out and forms a continuous connection with the periosteum, and then those collagen fibers basically are just running around the joint until they merge with the periosteum below. This whole thing is sort of like a Scotch-Brite pan. Strong fibers, very flexible, but completely encasing this. When you step down on your knee, you notice how it bulges out a little? Well, the reason it bulges out is because of this strong sheath. You step down with your weight and you put pressure on this hydraulic fluid. Now, when you do that, hydraulics, a liquid cannot compress. So it's going to press out with equal pressure depending on how much pressure you apply from the top. So if you think about these articular surfaces when you step down, of course, this pad is going to hit this pad and distribute the force all over this surface. But with the hydraulics in here, the force of the hydraulics is going to apply pressure all around this red surface, the inner part of the synovial cavity, which is lined with a kind of a rubbery, impenetrable sheath called the synovial membrane. So we're going to combine the lubricating and padding effects of cartilage with the hydraulic effects of the synovial cavity. It's really a marvel that we got all those elements. This is what makes our mobile joints so enduring. Now, when we build a knuckle or when we build a ball and socket out of steel, it wears a long time as long as it's well lubricated. But from the moment we start moving it, it basically wears away. So if you wear too much of the metal away, the only answer is to replace that metal piece. Whereas this is a living synovial capsule. There are living chondrocytes and osteocytes that are maintaining these surfaces, and fibroblasts that are renewing and maintaining the collagen fibers. And if there is exertion to the point that you begin to break a few fibers or even to damage the bone surface, living cells are present and they can renew this joint up to a certain amount of wear. They can renew this joint from within by simply growing new cells. So our joints can, with good luck, last a lifetime. Here's an actual joint. This one a hinge joint, showing you a good lateral shot, a sagittal section of the knee. The femur above, you can see the compact and spongy and medullary elements. You can also see that in the tibia below. Out here, the articular cartilage, because of the mobility of this joint, when this is bent, and you notice a good sprinter who's very flexible, will power through their step and push off, and this lower leg will rotate all the way around, almost fold up against the back of the thigh. So for that, we require a lot of padding of this circular condyle on the femur. It's sitting in two trenches on the top of the tibia. The fibula is not really involved in this knee joint. But you can also see other features of the joint that are important to understanding how it works. First thing we have to do is build this synovial cavity. Look how high the synovial cavity goes, providing so much surface area for the support of that hydraulic pressure as we use our knee. The synovial membrane is complete in encasing this. In addition to the articular cartilage, there are wedges of cartilage called the meniscus, left and right, or front and back. And they basically cradle that joint and basically provide smooth surfaces for their movement. When you're stepping down with full force, you will get cartilage on cartilage contact and sliding. When you move this joint, muscles are contracting and relaxing, which means they're being stretched back out. And that means they're going to be rubbing against adjacent tissues. And where there is a place where wear is possible, for example, there are four muscles up here in the front of the thigh that form this quadriceps tendon, and it goes over the top of the kneecap. Because it's moving back and forth, there's a good chance you'll wear that bone. And so right here we have what's called a bursa. It's a lubricating pad that reduces the friction between this moving patella and the epidermal tissue, the epidermal tissue, integumentary tissue, that's right outside of it. This patellar ligament connects the patella to the tibia. This is basically the muscle that extends the lower leg. And that extension is as important as the power stroke. You push off with the power stroke, and you flex, but you have to extend your knee so that the foot is there to catch you as your foot comes down, to catch you and keep you on your feet. Now, in addition to these elements that we've named, there are many ligaments that attach bone to bone, some involved in the capsule and some ligaments that simply run to bone surfaces. But there are also tendons, connective tissues rich in collagen, that attach muscle to bone. This is the motivating tissue. When the muscle contracts, that's what produces movement. In this case, the quadriceps will produce extension at the knee. Finally, it's kind of obvious that all of the other space is cushioned with globs of fat. These fat pads are sort of like the styrofoam peanuts in your shipping boxes. You basically put these peanuts in that will occupy all the space and allow for a little movement, so it will cushion any shock, and the peanuts are contacting the object in many places. So the force is distributed and your champagne glasses will not break. But after a certain amount of movement, they cushion and stop the movement. That's what these fat deposits around synovial joints are doing. They're filling the spaces between the bones, the connective tissue, the muscles, the bursa, the synovial cavity, and so forth. So this material is all moving, and it can move a bit, but it cannot flop around or wind around each other. Sometimes it's good to envision joints and explain their movement by looking at actual joints and a model that sort of represents how they move. Many joints in the body are gliding joints. These are non-axial or multi-axial. Notice flat plate on flat plate. So you're moving, sometimes in this direction only, sometimes in this direction and this direction. So this would be x-axis, this would be y-axis. The names of the joints kind of tell you where they are, and if you've been paying attention to your bone names, you're in good shape to understand which joints are being referred to. Examples of gliding joints: the Acromioclavicular Joint, which would be here, the point of the shoulder, and the claviculosternal joint, shown in the picture, the claviculosternal joint. This is a gliding joint. When you move your arm, you probably notice that you don't just move your clavicle forward and back. When you lift your arm up, that clavicle actually moves up quite a bit, and that's because of that gliding joint making this movement. There are many gliding joints in the intercarpal connections. So these short bones, the carpals, have many small flat surfaces, many joints. So if you look at the capitate bone, the base of the number 3 ray, that one that's kind of in the center of the wrist, you'll notice that it forms joints with about 5 or 6 bones around it. Those are all small gliding joints. Taken together, that means the wrist can be very flexible. But when you have to apply force, use your upper body strength, they jam together into a very solid bony block, and you can transfer all that force across your wrist without injury. The same applies to the intertarsal joints, the connections between our ankle bones. Finally, the vertebral-costal joints. Now here, if you remember the vertebra, there was the body-to-body connection in the front, and in back were those articular surfaces, the superior and inferior articular processes. And those are gliding joints. They allow for this kind of flexion and extension and hyperextension, moving up and down on adjacent vertebrae. Finally, the sacroiliac joint. Sacroiliac joint does not move very much, but because it has a synovial cavity, we call it a freely movable joint. It is basically the connection of the pelvic girdle and the pelvic appendicular skeleton to the axial skeleton. A hinge joint. Hinge joints are everywhere. Here we have rotation around an axis, basically up and down, monoaxial, moving in one plane. We know, for example, here at the pointer, if you imagine that as an elbow, we know that the elbow doesn't rotate on the ulnar joint. We also know that it doesn't abduct and adduct on that joint. It only flexes and extends. So examples of this, ulna and humerus, are shown here. The elbow joint, the knee joint, the ankle joint, and again that's the talus on the lower leg, and the interphalangeal joints. It's interesting to kind of check that out by simply looking at your hand. So when you do this, you notice this is a hinge joint. It moves in this plane. It does not move this way and this way. It does not rotate that much. This is a hinge joint that behaves the same. But here, you'll notice that finger can move in that plane, but also in that. This is a different joint. It's called a condyle. And it sets you up for understanding how they can do such remarkable things with just a few bones. So when you take the hand apart, you'll notice that the distal phalanx has a free end and a hinge. The middle has a hinge and a hinge, and the proximal has a hinge and a condyle. The differences in the joints allows you, once with just a little study, to identify the bones that we call phalanges. A pivot joint is for rotation. Atlanto-axial joint is shown here. A post on the midline that we call the dens of the axis provides the axle of rotation. This loop on the axis, on the atlas, fits around it and is even tied in with a loop of ligament. That allows the atlas to rotate left and right around the dens. So it is the C1 to C2 connection that allows us to shake our head, to rotate it left and right. Now, another example is a little harder to explain. The proximal radioulnar joint. So there is at the elbow a radius and an ulna, and the radioulnar joint is the one that is on the proximal end of the radius. It's what allows for rotation of the radioulnar joint. That's what turns the hand over, pronates the hand. It is not a movement in the wrist, it's a movement in the elbow. A condyle joint is like, this always reminds me of a mortar and pestle in chemistry, a bowl shape with the inside of the bowl and the outside of the bowl kind of reversed and allowing for this biaxial movement. Radiocarpal joint, the radiocarpal joint allows for condylar movement. The metacarpophalangeal joints 2 through 5. Metacarpophalangeal joints 2 through 5. These are all condyles. And it kind of shows what a complex appendage our hand is. So when we do something simple, we just say we grip with our hand or we grab with our hand. We're actually activating so many different joints to produce that grip. The metatarsophalangeal joints are also condyles. Those are the knuckles at the base of our toes. The saddle joint, we always usually leave that for last and next to the last because it is so unique. This is the joint that kind of defines primates because this is what converts our hand region to a grasping tool. In order to grasp, you need to put something completely around an object. So we do that by curling our fingers around, and then we oppose that with our thumb, and it is the saddle joint here, the first metacarpal joint right here that allows us, you can see that it sits on it kind of like a saddle, allowing for this very different kind of biaxial movement. That allows us to oppose our other fingers and grip with our thumb. It kind of explains why we have this great big muscle here. If we're going to oppose the strength of 4 fingers with one digit, even if it's the great digit, we're going to need a lot of muscular force on this side, and that's why we have this great big muscle pad here to hold that thumb firm when we're gripping something. The saddle joint occurs only in that location at the base of the metacarpal number 1 and on the proximal end of that metacarpal, and we only have it on the right and left side of our hands. Finally, and probably most mobile, our ball and socket joint. Now you can kind of see what I was trying to explain about axes. Here is one kind of movement. There is another kind of movement in this plane, so X and Y, and the third kind of movement is rotating. And because of that, we have hands and arms that are very useful. We can rotate our shoulder if we want to turn our arm over. We can further rotate and at the elbow. And those particular motions make our hands very adept at dexterity, so we can basically do amazing things independently with our fingers if we train them. But if we're climbing trees, the trees and the branches don't grow at the same uniform angle. Sometimes we're going to have to grab something that's pointing straight up and down, and that means repositioning our hands. It's kind of interesting to look at the hand structure in the great apes, especially the orangutan. The orangutan is the most arboreal of those great primate species. And the hand is very elongated, with long fingers, which the orang uses basically to just loop over like a hook to catch the branches. The thumb is tiny. It's down here on the wrist, and basically when it's swinging, it basically squeezes that thumb in against the fingers. And that's kind of an adaptation to arboreal travel. And the reason is that if you put your hand out like this and catch that branch, you break your thumb right off. So the orang tucks it out of the way, uses his hand kind of like a hook just over the top. That allows you to swing as well, doesn't endanger that thumb. So examples of ball and sockets, the shoulder joint and the hip joint are the largest and most prominent ball and socket joints. And they are the ones that mount our four appendages and give us the dexterity of use above and the power and mobility that we enjoy below. So the rest of this PowerPoint will be a travel through some of the joints of the body, showing how these types of joints combine to provide the very complex structures. When we talk about a movement, we can illustrate the movement in definition by immobilizing the body and only moving one joint. But when we move our body, we're using many muscles and moving many joints at the same time. And I think that there's no place where this combination of different joints and different connective tissues shows how we tie these bones together into a strong axis that remains flexible. Think of what it does. This column of bodies provides the main support for the entire trunk of the body. Back here, this circle of bone in the back, the pedicel and lamina, creates this vertebral foramen that encases and protects the spinal cord, allowing for flexibility, but still protecting it from outside shocks. These features, like the transverse process and the spinous process, are rigid levers for the connection of a broad array of muscles. So back here, we have to be especially concerned with posture, because we have to keep these bony bodies aligned so they are held into a cylinder in order for us to support our body's weight. The rule is this: good posture means putting your weight on the bones. If you're holding your body in such a way that weight is being supported in a permanent way by the muscles, that represents a strain. That represents a misalignment of the skeleton. So what do we see here? A vertebra that's been cut away, the body, on the body, joined by this intervertebral disc, a symphysis. To all intents and purposes, there's nothing that resembles this so much as the gel pad that you find in the soles and heels of your running shoes. It has a tough outer surface like this end plate. It has a fibrous donut with strong fibers, basically giving flexible strength up and down to this pad. And in the middle, this is drawn as a kind of a fatty component, something that is like lobs of fat, a gel-like substance that squishes and compresses as these two move closer or further apart. This also gives you the ability, just like in your running shoe pads, to tilt. If you basically pull this vertebra posteriorly, this turns from a pad into a wedge, pinching down here and then being pulled wider on this side, but always adhering to the body. So we have this stack of symphyses holding the column of support firmly. We are illustrating here also the presence of the spinal cord and the spinal nerves that come out through that hole in the side, the intervertebral foramen. This nervous tissue is wrapped in several layers, and we see other layers of connective tissue. The ligamentum flavum is tying at the back of the lamina to lamina, which basically is covering this open and these open joints and protecting the rear posterior part of the spinal cord from the movement that's occurring. Here we have a posterior longitudinal ligament. Notice how it curves around, providing connection to bone, and then also forming this anchoring to the outside of the fibrocartilage pad. We see that kind of wedge of support is covered over with parallel and vertical collagen fibers from just across the pad on the outside and tied into the collagen on the bone, and then finally wrapped with this anterior longitudinal ligament as an outside sheath. Notice that it goes all the way around the back, wrapping the entire thing. It's been cut away here. And the regions, the supraspinous ligament and the interspinous ligament, are continuous around this entire structure. So all told, the strong and flexible components of the connective tissue, especially with collagen fiber, the cartilage that's present in the symphysis, the hyaline cartilage that lines these, basically these articular surfaces that you see here and below, all of this puts this spine together into a strong and supportive axis to the body, and one that functions very well through our life. When we have an injury to the fibrocartilage pad, such as shown here, it changes this anatomy quite dramatically. So what we're seeing here on your right side, the left side of this vertebra, the transverse process, this is the superior articulating process and the superior articulating facet exposed in its position. This is the spinous process. Shown within is a cross-section of the spinal cord with the gray matter and white matter, left and right, and the connecting spinal nerves, left and right, that are attached at this level. Now on your right side, you can see a kind of a almost normal configuration with this fibrocartilage pad, the annulus fibrosus, and the nucleus pulposus in a central position. But if this cavity ruptures, then it squirts this nucleus pulposus out into gaps that separate this annulus fibrosus and distort it. You can see what it's done here. It's kind of bulged out and pushed through in a posterior direction. Now what this has done on the left side, your left, the right side of the body, is that it has narrowed this intervertebral foramen and applied pressure to the nerve. So this pressure can be translated into pain, into paralysis, into interference with sensory and motor signals that are entering here. So it affects this right side spinal nerve profoundly. Now, the greater the distortion, the greater the pressure, the more the damage. In some cases, surgery can realign these, but a more popular approach is typically to remove this disc and fuse this vertebra with the one above it. You lose a little bit of flexibility, but the movement that is causing the compression, the shock to the spinal nerve, is removed. So this is what's called a herniated disc. Now, within the chapters, you're going to find wonderful specific information on the skeleton and its specific joints. And in answering questions about that, you'll need to refer to kind of double check your thinking. Let's look how these are organized. The vertebral column that we just looked at, this occipital bone to the atlas. This is the mounting of the skull on the top of the spinal column. We call that the atlanto-occipital joint, and it is a diarthrosis, so synovial cavity and a condyle. That condyle allows for flexion and extension. Nodding the head depends on this joint, a condyle. The atlas to the axis we already discussed. The atlanto-axial joint is a pivot diarthrosis, so synovial cavity, and rotation left and right are the movements. The other vertebral elements, when we look between the bodies, that's that amphiarthrosis, a symphysis from the fibrocartilage pad. It allows for slight movement, but it is actually allowing for movement, in a kind of a 360-degree bending and flexing direction. The articular processes at the back are diarthrotic and are also gliding joints. Those are those flat planar joints that allow for diaxial gliding. Again, complementing the fibrocartilage pad in producing a kind of a continuous flexibility around 360 degrees. So a little bit of rotation is allowed there at the back, along with flexion and extension of the joint. So seek specific information in tables like this in your text. When we have to secure the more mobile joints, we do that with a lot of connective tissue. The synovial cavity and something like a ball and socket are there in order to manage and maintain a huge range of motion. Flexibility is actually very good for our arms and hands. But here we see reinforcement in a degree we have not seen previously. A ligament is a connective tissue that spans across a joint from one bone to another. And you can see the example of what we commonly have viewed. The acromioclavicular ligament here, attaching these two different bones. The coracoclavicular ligaments, attaching a different bone marking between the clavicle and the scapula. But here's a very unusual ligament. This coracoacromial ligament is actually connecting two bone markings on the same bone. It basically secures this bone against bending, against the coracoid process moving too far from the acromion. We do see the elements here of the bone, spongy and compact, forming the articular surface with its hyaline cartilage, encased by this synovial cavity with its fluid membrane. Now you notice that the glenoid cavity here on the scapula is actually pretty shallow. It's less like a bowl and more like a saucer. So although it provides for a lot of movement, if you can imagine abduction of this joint, basically abducting the shoulder all the way up around. You can look at the range of travel this big, broad head allows when you're abducting the shoulder. But this is such a shallow joint. It allows for a lot of movement, but it is also relatively easily dislocated, often in the anterior direction. Here we see a bursa that's very extensive because we're going to attach muscles. For example, my favorite muscle, the biceps brachii, is going to run a tendon across the top of this joint and connect it to the superior part of the glenoid cavity, right here. So that means it's going to be sliding over the top of these bones. Bursa are present, sort of like lubricating pads to allow that ligament movement to occur without cutting into bone. When we look at an elbow with just the bones, it seems lumpy and kind of odd shaped, but when we wrap them in the tendons and ligaments, we can kind of see the purpose for every one of those bone markings. Here, this medial epicondyle looks like it basically flows continuously into these collateral ligaments. Notice that the ligaments form geometric shapes that kind of resemble triangles. Triangles are rigid figures that do not allow movement, and so they bind this joint together very tightly. We also see ligaments that wrap. So here's an annular. Annular means a ring-like structure, and it goes from the ulna all the way around the head of the radius to the ulna again on the other side, forming a ring. Now that allows the head of that radius to rotate within that ligament, but still be held tight against the ulna. That's this motion here when we're rotating from the elbow. This looks the same, but this is not a ligament. Its attachment has been cut away, but this is actually the attachment to the biceps brachii muscle. So this collagen is there to pull on the radius. When we flex the elbow, we contract the muscle body above and free this joint up by relaxing the antagonist. And it basically causes the ulna to rotate on the humerus, and we flex the elbow, moving in this direction. These types of diagrams, you can see the interosseous membrane locking that radius and ulna together so that they act more like one bone. This collagen of the ligament and tendon tissue provides for very strong, but also growing and renewable elements of our joints. As strong as the shoulder may be, the hip joint is much stronger because of its responsibilities in terms of managing weight and movement. So this is the joint that accounts for our propulsion, for our ultimate speed, for our jumping, for our landing. You can see the acetabulum, that bony cup that we saw earlier in the coxal bone, is surrounded by very rough and pitted projections, many bone markers. Look at this spine. Look at this crest. This all represents, and especially where it's pitted here, these are places where there are strong ligament and tendon connections to hold the hip together. But the hip requires a little bit more special connective tissue. You can see the way we've stitched around the outside, the iliofemoral ligament, the fibrocartilage pad of the acetabular labrum. The ligament that is shown here is really quite unique. It attaches to the bone of the coxal bone, runs across the center of the joint, and this has been cut. However, it basically, when it's intact, it runs straight into the collagen that's embedded in the femoral head. So as the socket is like this and the ball is like this, and it's rotating like this as we walk, when it tries to move this way, that ligament of the femoral head comes tight and keeps it from pulling out of joint. So this is a very much stronger joint. And when we wrap it at another level, this is the anterior view, now you see the purpose of the greater trochanter to less trochanter and that intertrochanter ridge. Do you see how it forms a rim? One of the things I'll point out is, do you notice how the ligament comes from the back, wraps around the head, and then attaches to the bone above? So when you go from a narrow region across a wider region, it provides an additional kind of tightening. You'll also notice that these fibers are coiled. In some joints, it's enough that it kind of resembles a rope. What do we do with fiber to make rope? We coil it. We spin it around each other, and that holds it together, but it also gives it a strength. Now, the interesting thing about this coiling is the direction it is in. When we take a step, what I'd call a power stroke, so our foot comes down and we rotate our weight over that foot as our body moves forward, and we push off with our legs and feet. The power stroke tightens these coils and draws the femur into the head, making the joint more secure when we're applying force. Now, at the end of our step, our foot comes off the ground, the weight comes off of this bone, so it kind of drops away because the weight is no longer being transferred for that joint. And we begin to use things like the quadriceps tendon to flex the knee and other flexors to bring the thigh forward. And these loosen, dropping this out of its, loosening in its socket so that it rotates forward with much less friction. Some of these considerations that I mentioned, they fascinate me. This is what we call biomechanics. And we discover these principles and use them whenever we engineer something. So we use all our knowledge to engineer strength and flexibility in the things that we build. But this joint, just like all the other joints in our body, is produced by cells working together. Individual cells growing and making these connective tissues and connecting them to muscles so that they move. And they can basically grow and modify by, a cell-by-cell basis. So if there's some genetic change that makes this ridge a little larger, and that allows for more ligament connection, that means you run and jump and your hips don't wear out. You live longer and you have more children, then the genes for that are preserved. That's the thing about an organic structure, is that its blueprint is always in the DNA. And that blueprint is constantly changing by mutation. And natural selection is taking those changes that help you survive and reproduce and preserving them and amplifying them in the population. So in a way, this kind of passively changing joint is improving its operation constantly. The anterior portion of the knee, a hinge joint, wow, this is a really delicate joint. This is one of the joints kind of right there in the middle of our leg, involved in all our heavy running, involved in all of our changing direction and uneven ground. Notice that the tibia and the femur form the knee joint. The fibula basically forms a side joint here with the tibia. But even though it's not directly involved with articular surfaces in the knee, these ligaments like the collateral ligament from the fibula to the femur do help stabilize the joint. This is that quadriceps tendon in the base of two of the vastus muscles, the lateralis and the medialis, that come together and suspend the patella, the kneecap, in front of the opening, and then provide this patellar ligament, which basically when we contract this, we're going to pull on the tibia to extend the knee. The knee is very complicated, and there is a real reason. Here's the femur. Here are those condyles, the lateral condyle and the medial condyle, those huge rolling surfaces that you see on the bottom of the femur. We saw it when we looked at the patella in the last chapter. But this gap here was something that we didn't explain. These two condyles rest in bowls on the left and right, which help hold them in. But we not only wrap this joint in a sheath around the outside, but we take ligaments that are attached to bone and connective tissue like cartilage and run them in X's across this gap. So from top to bottom, from left to right, we anchor this joint, and these connections across the middle keep it from pulling apart. They allow it to take pressure off during the recovery of our legs to begin the next step, but they basically keep it from going too far. Look to these tables again when we are defining specific joints and how they work. The actual details are present in the chapters. So let's just take one, the scapula and the humerus. That's the shoulder joint, shoulder, or gleno for the glenoid cavity, humeral for the humerus joint. This is a ball and socket diarthrosis, one of the larger joints in the body. And because it's triaxial, it can flex and extend, it can abduct and adduct, it can circumduct and rotate. That's the rotation dimension. So we will not cover absolutely every bone and every joint in the body, but I wanted to give you a flavor of what you'll be doing in lab when you are identifying and categorizing these joints. I'm going to supplement this in upcoming lectures, hopefully starting on Wednesday, with worksheets that allow you to work several problems. I would refer you to the text as reference for the specific answers to this. One of the confusions that we have and that you will face is that we are accustomed to just using our body. So we get up and walk across the room. Well, it would be very difficult to write out every one of the movements, every one of the joint articulations. What is, the principal movement of a particular joint during that gross body movement. But breaking it down into these tables does help us understand what individual joints are doing. So I'm going to end the show. I know this was a rather long presentation, but it is more handy to have it in